Thank you, Miss Ksenia. Thank you so much. And this was like an invitation to potential Q&A session, but okay. I'd like now to continue. Okay, let's take different perspectives concerning the TBI. And now I'd like to have the Minister of Veteran Affairs, Ms. Natalia Kalmykova, please. You're so welcome. Thank you. And first of all, I'd like us again to, let's have a round of applause to Ms. Ksenia. Yeah, let's do it again. She has seen this invisible enemy. She was one of the first, actually, to do that. She put so many efforts for us to finally, for the number of experts, people who are professional, who have the expertise, and who work with evidence-based methodology, for these to expand and have those discussions today. So truly, when we do talk about invisible enemy, we have to understand who are the allies in that battle, who are in the team. First of all, the person, the one who has TBI. And I just want to step from the veterans to servicemen and women, because this whole thing happens when you're in duty. Okay, what's happening when you're in service and duty? So people quite often don't realize that something's wrong. Just saying I'm fine, ignoring that, ignoring the problems. There are commanders also who don't understand that something's wrong and don't pay enough attention to it. And this is something that we've spoken of when we had the Congress in July. We were the key audience, the target audience was not the medical and psychological community, but the commanders community. People who have to understand that it's not just the Russians they fight with, but they fight with these invisible enemies as well. So we also have a problem related to, like, it's about lack of staff. Okay, people who can actually ensure and give proper medical and psychological support to officers and servicemen and women, and now the Department of MOD is doing everything for the medical staff, for doctors, to have the MH gap expertise and make sure that they cover the gap, cover, as we call it, the gap, yeah? When they're supporting people with TBI, military with TBI. Okay, then we move to another point. When person goes to a healthcare facility, as you mentioned it properly, so now we have 80% of military treated in civilian hospitals. And we have to get the staff well aware, professional, in both military and civilian HCFs. They have to be aware, know what to do, what is TBI, how it's manifested, and actually what to do with that. So many things depend on that, and especially the intensity of consequences, midterm and long-term consequences, it depends on their professionalism. And such discussions on training is a priority. And this is an important tool for us to decrease and minimize and mitigate the consequences of war for our defenders, men and women both, and for their families who get the first impact. And of course, for all the society in total. So Ms. Ksenia also mentioned very properly that now, and part of the protocols already were already adopted, not just drafted by the MOH, because when you work purely according to protocols, this is the proper way to do. When you use the same clear methodology, and when there is a transfer from one professional to another, everybody understands, everybody realizes what is done, what should be done. But I just want to stress on the following, that unfortunately now we have this unique expertise which none of the countries has. And again, when I was in MOD, we started this work together with partners from the medical forces, of NATO countries, that their protocols have to change, have to adapt. Based on that experience that we have already in Ukraine, that our Ukrainian professionals do have, and something that is absent in the US. Accumulation and generalization of knowledge, unification of knowledge, and experience. This is a big task for medical community. We have to generalize data properly, correctly, making proper decisions based on generalized, verified data, not because I think so, okay? Not because this is my opinion, no. Ksenia also said that you use non-evidence-based methods, yet unfortunately these are still applied. And if you come to any HCF, any hospital, actually we'll see the miracles of non-evidence-based medicine. We can actually treat that differently. We can think like this is like the element of spa. But well, limitation of resources, limited resources require the use of evidence-based methods. So the role of Ministry of Veterans Affairs and the system. We are the requester, okay, on behalf of the veteran. And now we're building the system where we communicate with those central executive power bodies that do have this industry, like the MOH, when it comes to needs of veterans. Now in MOH, we already have a decree under processing that will change the approach to funding of examination for veterans, both men and women, because men and women, I mean, for those who are veterans, they have other condition and status than civilians of the same age, and they will require there will be a higher frequency to family doctor appointments. Okay, family doctors have to understand what's happening and then refer to specialists and experts. These people require more examinations, you know, and I'm so grateful to Ministry of Health that this idea is supported. And we expect for this decree to be adopted soon and start working on that track. Because, you know, we need to catch this invisible enemy at the very, very beginning. This is the most important task, actually, that we have to solve all together, like allies, you know, like a coalition, in the interest of Ukrainian citizen, you know, Ukrainian citizens, those Ukrainian citizens who took weapons to defend us. Millions of people, these are millions of people. This is the impact of our ignorance will be huge. We can't see it now, but before I came here, I had a meeting on employment of veterans. By the way, this stigma exists, and this stigma is somewhere it's exaggerated, but somewhere these are actual cases that people use as grounds. Something says something to someone. Okay, so we have to work not just to communicate this to people, to articulate this. Veteran is a normal human being, but with some combatant experience. That's it. But also to make sure that communication meets reality. For communication, for us as a state, less for us as experts, for us as civic society that we have here today also, we have to do everything for health condition of a person to restore to the best level possible. Okay, the highest level possible. And the last thing I want to draw your attention to, the whole community, I mean the professional community. This is about liberated, people who are liberated from captivity, ex-prisoners, and POWs. So this category is still like a big gap, and we don't know what to do. So basically, we don't have protocols how to work with people who were malnourished for a long time, how to restore, how to feed them properly, let's say, at a basic level, because for nutrition not to lead later to heart problems or kidney problems, okay? We don't have, nobody in the world actually has the protocols to know how to work with this expanded category of people who are liberated. We know how to work with civilians, because if military, they're under the protocol, so they go to HCFs where they are provided with support of certain quality, let's say. But they are people on duty. But civilians, they just go to civilian life. Quite often, they don't even realize, and they are ashamed of asking for help, you know, when they return. So this is a very underregulated thing, and as of now, we don't have an answer for it. When we draft protocols, when we ensure the treatment algorithms, I don't like when we say the word rehab when we speak of veterans. It's just a part of the process, actually, the rehab itself. It's just a part of a big medical process, medical path. It's how we support the health, physical and mental health, you know, providing this follow-up for a person who has the competent experience till the very end of one's life. So we have to pay attention to that. We have to produce solutions and best decisions and apply these all together. Okay, so we are doing everything, of course, to start like examining and providing more high quality and giving more access to primary healthcare PHC, which later has to shift to specialized level. Also, the PHC experts have to acquire MHGAP knowledge and expertise. It's not voluntarily, it has to be mandatory. Because, again, the number of people in Ukraine, both civilians and military, those with TBIs, it's a huge number, and they have to be aware of that. And now we already started working with, we're trying to change the perspective and approaches now to rehab processes when it comes to competence after traumas, injuries, and also mild TBI. The same. So I really want you all to have very productive discussion, and I do hope that PR people we have here will bring out a lot of very specific material out of this place, which will be heard not only by doctors, not only by experts, not only by professionals, but also, first of all, by commanders. I want them to hear that, who will understand that the person is not pretending. The person is not trying to leave, or trying to flee, or to, like, this is a problem, actually. For them to be, to stick to recommendations of medical doctors, to be attentive, those medical doctors that we have in units, respectively, that commanders will listen to military psychologists as well. I see some of you here, and we definitely will be able then to manage the process. We can't overcome it completely, but we can manage it. Thank you for invitation and have a nice discussion. We are grateful to you as well, Ms. Natalia. Thank you. And we are ready to move forward. We know that actually a huge number, so everybody in this space are quite busy and they had a huge number of things to do. Yeah, a lot of. Okay, so we continue with this discussion, but again, with an opportunity to move forward and perform your duties. Okay, so we'd love to have our good friends here. Today we have representative of the U.S. Embassy, mental health advisor from USAID, and we have Megan Williams with us.
Thank you so much. It's great to be here today. Good morning, dear colleagues, distinguished panelists, honored minister. It's an honor to be here. The United States and USAID stands beside you in support of Ukraine's veterans and brave people. We're all here today because Ukraine's veterans and civilians are caught in Russia's brutal attacks of aggression and experiencing traumatic brain injuries. And TBIs can be complex with physical, cognitive, emotional, social components. And so TBIs demand holistic, high-quality care. And USAID is supporting this care in several ways. We've partnered with Lucilva Poliana to help develop the online course in mild TBI, which was mentioned, which is now available online through the National Health Service of Ukraine's online learning platform. You've heard mention of MHGAP. We're proud to have supported many organizations in rolling that out too with the World Health Organization. We also support and prioritize developing the capacity of the physical and occupational therapy workforce, who are also essential allies in treating TBIs. To date, USAID has supported upskilling of more than 2,000 rehabilitation specialists to address a range of conditions, including TBI. In November, we will launch Rehabilitation for Ukraine, or Rehab for You, with the Ministry of Health and Ministry of Social Policy. This new 5-year, $40 million program will expand physical rehabilitation services for all Ukrainians, including veterans. Rehab for You will integrate evidence-based patient functionality assessment tools into the national e-health system, including tools for assessing TBI. It will support education and training of physical and occupational therapists, partnering with 5 Ukrainian universities for developing advanced physical therapy programs and 3 Ukrainian universities for advanced occupational therapy training. And perhaps most importantly, Rehab for You will bring physical rehabilitation services closer to the communities where veterans live. And we will pilot integration of physical rehab services into primary healthcare facilities at the Hromada level. Community-level care is important for many reasons, but one of the most important is that communities are where the families live. We know family support is critical for the veterans' reintegration. There's much joy when a hero returns home, And there are also challenges. And this situation of homecoming can be even more complicated when the hero returns with a brain injury. And on this topic of family support, I also speak to you not only as a psychotherapist, but as a former caregiver of a family member who had a brain injury myself. TBI symptoms often overlap and compound with other mental health issues. The unexpected ups and downs in mood and energy can be very confusing. So, what are families to do? How are we to support wives, husbands, parents, and children in their critical roles? We must first empower families with knowledge. The first step is for families is understanding what a TBI is, how it can affect their loved one, and how they can help. Accurate, understandable information helps prepare families for the ups and downs of the TBI journey. Second, we must strengthen coping skills. Families are resilient. Mental health and psychosocial support can build on this resilience, improving communication skills, stress management, emotional regulation, executive functioning. These skills are useful not only for TBI patients, but also family members. Finally, we must foster increased connection. We know social support, especially from family, is vital to so many important health outcomes. And so we need to target this social support as an intervention in itself. Building healthy communication between couples, strengthening families, and linking TBI survivors, indeed all citizens going through rehabilitation, to community groups. And this will provide the critical social support needed on the journey to health. And once again, this brings us back to communities and excellent care at this level. USAID is excited to be working with Ukraine to continue to build out the rehabilitation ecosystem into communities. We hope to further expand our current support for mental health in line with the government of Ukraine and the First Lady's ambitious vision for a holistic mental health system, from the national down to the local levels. USAID thanks you for this opportunity to share and participate in this vital initiative today, caring for heroes and civilians, both now and in the future. Thank you.
Дякуємо вам.
Thank you so much. Thank you so much. Thank you for all this support. Thank you for all the support that U.S. Embassy is providing to Ukraine in general, and for the support that was given us to organize the Congress. Okay, so we can move forward. We have two other panelists. We'll be so happy to offer the floor to them, and a big, big, big request or an offer. We have like 20 minutes before we have Miss Katie. Okay, 10 minutes each panelist is getting now. So I'd like to have with us Deputy Minister in Health and Veterans Policy. We have Alexandra Parhun. You're so welcome.
Доброго дня. Радий сьогодні.
Good morning. I'm very happy to be here with you. Thank you, Ksenia, for such an opportunity to gather here all the persons who can discuss the consequences of concussion, how they help the war fighters, how they help the veterans journey into civil life, how they provide the rehabilitation, since this is a task not only to a whole variety of ministries, but first of all, this is a responsibility for our country to give the honor to in all the support to its defenders. So, for example, I got 6 traumas of this kind during my 11 years of life. I understand how to live with them. So, yes, this is life, but you have to control yourself every single moment to follow to monitor your health condition, I name them my small friends. Why? Because they are like friends giving me some, let's say, prompt me into what to do next, to visit a doctor or to do something else. And I would like to say that this is not the end of your life, but just the beginning of your new life with new colors. And when being more specific, that the MOH is really interested in creating in our country the rehab and the rehab guidelines on the modern up to the level, accessible level, and together with Xenia and the Lisova Polyana Center of Excellence, we developed the guidelines in order to provide qualitative treatment, but first of all, really good and easy identification and diagnosis of the MTBI, and to assign where you can address and to whom you can address, and also the referral ways for treatment, and to really to establish the guidelines that were provided to management and treatment to TBI, to people with TBI. So we developed the structure for the whole program for centers of excellence. There'll be 7 of them, and they will provide the qualitative rehabilitation, namely in studying, identifying, and management of war trauma. Lisova Polyana Center is also included in this network. So what they do, first of all, they provide management, TBI management, and also they train the specialists, medical professionals into the specific areas. For example, Xenia trains psychologists who then after go to the local clinics to provide help to the former prisoners and war veterans, and helping them in the management of their trauma. This is very important since the civilian healthcare professionals, they don't know how to manage the war trauma. I have the right to say it since a war veteran, and really I went through this way on dealing with the civilian doctors and trying to explain them my problems. So, but we have to make the way, like not only the civilian doctor is ready to help the war veterans, but also war veterans to be ready to address, to visit the civilian doctors. And our task is to change this paradigm, to improve it. And it's not a problem to visit the psychologist and to tell him or her about your problems. And so that's I invite all the war veterans really to go in, to visit the psychologist. If you don't do this, it will get worse. Say, and also we would like to cooperate more with those countries. You already developed some strategies and systems to overcome and manage the concussion and the similar traumas. But I would like to emphasize here that the experience that we're getting here, none of the countries has, namely what happens in the front line in the city, since lots of civilians suffer from the let's say the concussion trauma because of the shelling and explosions. And yes, we hope that MOH professionals in all the organizations similar like Xenia do, they will help us to develop and implement the guidelines. And here I would like to stress upon that not only doctors and rehabilitologists should work in this ecosystem. Yes, doctors have to treat, to rehabilitate, and to provide all the possible conditions for the war veterans to socialize, to get back to life. But all the levels have to work for this in order to help the war veterans at trying to get back to the civil life. So here should be the Ministry of Economy involved to provide the employment, the Ministry of Defense also to help the war veterans. Yes, to summarize, yes, MOH should serve as a platform to develop the protocols and guidelines and standards and to implement them into the healthcare facilities, to develop recommendations to the MOD to implement those guidelines and standards in their clinics, I mean veteran clinics, in order to provide the qualitative rehabilitation and treatment. And all other ministries should also be involved into this work. Thank you. Thank you very much, Alexander, for sharing not only your professional but your personal experience, and this is quite valuable. And let me give the floor to the Deputy Commander of the Armed Forces of Ukraine, Yuri Podolyan. Thank you very much. Dear colleagues, I'm the Commander, the Mayor of Armed Forces of Ukraine. Please speak closer. I planned to participate personally. I mean, my commander planned to participate in person, but unfortunately the plans changed. So I would like to welcome you on his behalf. So the mild traumatic brain injury, so its problematics cannot be overestimated, since the quantity of veterans who received this MTBI, there's thousands and thousands, and thousands of them received the secondary MTBI. And we know that MTBI plus acute chronic stress decreases the let's say, the military availability of our soldiers. So, colleagues, well, to the Congress participants, I would like to wish to voice every single issue of rehabilitation and treatment for the for our servicemen and veterans. Since we work all together, we have to work all together to let's say to support and protect the health of our defenders. This is for the sake of our armed forces and for the sake of our people and of Ukraine. Thank you. Okay, let's check time, and now we are at 50 to 10, and We have 10 minutes, just 10 minutes in order to launch this process that Ksenia mentioned at the very beginning. I mean, it should be like two sides discussions, not only panelists to speak out, but also now the audience, to initiate the audience to ask questions, to also to provide their comments. So let's try to launch this two sides process. Let's initiate questions to any one of our speakers or to the whole panel. So please raise your hands in order to show that you're ready to participate in this process, and let us communicate. Okay. Katie is ready in case so, if so. Okay. Prior, Katie will provide her slides presentation. Say, I would like to mention that we really got interesting process with our speakers, and for Katie is now 3 a.m., but she refused to provide just a video record. She said, say, I would like to be together with Ukraine. And Chris, for example, recorded her video like 2 minutes before Milton, and so she managed to do it. Now they're in a blackout, so she managed to do. To record her video. Yes, the U.S. side really got an interesting, let's say, attendance of our conference. So, Ksenia, your Indonesian is really working well. Yes, Kathy, also a former military, and now we have the Warfighter Brand Health Center. Kathy Lee. Kathy, you are with us.
Yours.
Thank you. Communication good?
Yep, we can hear you perfectly well.
Okay, thank you so much. It is my pleasure to have an opportunity to participate in your International Congress on Mild Traumatic Brain Injury, the Signature of War. Next slide. My name is Kathy Lee, and I serve as the Warfighter Brain Health Policy Director for U.S. Department of Defense Health Affairs. I go slower. Next slide. So, want to share with you the scope of traumatic brain injury in the U.S. military health system. So, just run through some statistics so that I can paint a picture of what the traumatic brain injury issue is for the U.S. So, between the year 2000 and the first quarter of 2024, a little over 500,000 service members were diagnosed for the first time traumatic brain injury, the full continuum, mild, moderate, severe, and penetrating. You can see 82.2%, the vast majority, were diagnosed as mild or concussion, followed by moderate, only 1% severe, and 1.2% penetrating. Most of the TB, traumatic brain injury, is found in our active duty component. The annual number of brain injuries rose to about 10,000 per year, to a peak close to 33,000 in 2011. And finally, our entire system of care sees an estimated 14,000 to 17,000 visits to look for traumatic brain injury. Next slide. So I was asked to discuss how the United States responded to traumatic brain injury and what the history was leading us to today's Warfighter Brain Health Initiative. And we responded to the increasing rate of traumatic brain injury through expanding our clinical care capability and also our research so that we could have a better understanding of brain injury. And from those investments in research and experience of our clinical providers, we were able to initiate multimodal assessments. So not just relying on symptom reporting, but also relying on cognitive balance, symptoms, and other indices. We also developed policy, which is very important to maximize standardization and utilization across the entire military force. In 2018, we also noticed that those who had not an injury level, but continued subconcussive blast exposure could also have brain health changes seen in those with actual concussion and injury. Next slide. For that reason, the US Department of Defense stood up, developed a warfighter brain health initiative. And this was aligned to our entire DoD Department of Defense mission, which is to defend the homeland and to maximize deployability, and also to take care of our people and to optimize performance on and off the battlefield. Warfighter brain health is across the entire Department of Defense, not just medical, but also across intelligence and security, acquisition and sustainment, policy, and all the military departments. Everything we've been doing to address traumatic brain injury is now nested and underneath and integrated into the DoD's Warfighter Brain Health Initiative. Next slide. This is a picture of what the initiative's goals are and what are the components of warfighter brain health. Our mission, I want to highlight, is the fact to act rapidly, not to wait. We have a saying that we will bring out the 80% solution. Does not have to be perfect, but to get a solution out to the field. We have 5 lines of effort. The first one has to do with optimizing cognitive and physical performance. Line of effort 2, specifically identifying, monitoring, and mitigating through safety initiatives, brain exposures. And one of the main brain exposures is blast overpressure. Line of effort 3, prevent, recognize, and minimize the effects of brain injury. So this is all of our initiatives to try to create innovations in treatment, early detection of brain injury and concussion. Line of effort 4 is to reduce or eliminate the long-term or late effects. And what we mean by that is people that continue to have chronic symptoms and have other comorbidities, such as PTSD, substance abuse disorder, and other mental health issues, and also chronic pain, and also to eliminate the late effects that we have found on postmortem brain tissue, such as chronic traumatic encephalopathy and other neurodegenerative changes. Finally, line of effort 5 is to advance all the science in all of these domains of cognition, blast overpressure, traumatic brain injury, and the long-term and late effects. Next slide, please. So the evolution of our care began with injury, traumatic brain injury. 2007 is when US Congress gave money for lots of research to be conducted. And then specifically in 2012, we started wearing blast sensors. Actually, I have one right here. Blast sensors that we could put on our wearable sensors to evaluate the pressure of blast. 2018, we noticed that low level, not adversary blast, but low level blast in training exercises over time could be causing repetitive low level blasts to cause brain changes, mainly in the realm of reporting of symptoms, neurocognitive, and neurosensory, balance, and eye tracking. So in 2022, the US Warfighter Brain Health Initiative was developed, was planned, and it took approvals and was finalized in 2023. Next slide. This is probably the most important slide. The US DoD approach to prevent, recognize, and minimize the effects of brain injury. So this is mainly the brain injury concussion slide. And underlined are the most important areas to draft. We have drafted and enforced policy, established a pathway of care that starts with battlefield through rehabilitation. Identify and standardize the clinical tools to use, as well as clinical practice guidelines and recommendations. Then, to ensure that the military departments standardize and put through policy training and education so that the workforce and providers are trained on the appropriate clinical tools and clinical practice guidelines. Investing in innovations in brain injury to start with material solutions and prevention all the way through rehabilitation care. And then ensuring documentation for all of this data so that we can evolve lessons learned and improve our approaches and our tools that are used. Next slide. So in the deployed combat setting, we have a widespread awareness about what could cause a concussion or a potentially concussive event. Our policy relies on defining potentially concussive events, which leads to a mandatory medical evaluation and 24 hours of rest. And this is outlined in US DoD policy. Next slide. So, to talk about PCEs, or potentially concussive events, we have started to improve and refine this. And these are the events defined that require mandatory medical evaluation. So the event defines that you go in for care, not that you raise your hand and say, I think I need to get checked out. We don't leave it to the service member to decide that. We define it by the event that is highly capable of producing a mild traumatic brain injury or worse. And these events are defined. I highlighted the blast, presence within 50 meters of a blast. Back in 2008, we started 50 meters, unsure if that was the correct area, distance from a blast, and it is held up pretty well, 50 meters from a blast. But we do plan to make some changes and make that broader, and I will talk about that in a second. So a direct blow to the head or involvement in a vehicle blast event. We continue to try to define what is a potentially concussive event that will lead to a mandatory medical evaluation and screening. Next slide. So the screening has two things to look at, two goals. The first goal is whether or not there's a more serious brain injury and emergent care should be provided to the member. And that's related to the second bullet here, the use of blood biomarker technology. And so now we have been able to draw blood, whole blood, and use that venous blood to look for proteins that get put in the bloodstream after injury that can be indicative of a more severe brain injury that would require evacuation. So that is called the ISTAT alinity. And then the second objective is to see if the service member meets DoD concussion definition. So emergent care and the blood biomarker go hand in hand, go together. Next slide. You are probably aware of the US concussion screening tool called the MACE-2. We have been using the MACE since 2006. We updated the MACE in 2018. And it's an acute assessment tool for medically trained personnel. We currently do not have a buddy aid tool that for evaluation for someone that would need to go to medical. We define it based on the potentially concussive event. This MACE-2 tool is multimodal. So it looks at eye movement, balance, cognition, report of symptoms. And we also, on the MACE-2 tool, have a question that asks about past medical history. The past medical history of previous concussion, mental health issues, and a history of migraine or headache. Those three past medical history has been shown to prolong recovery from a concussion. Next slide. We have a tool called the Progressive Return to Activity. It's the second tool, the MACE-2, and then Progressive Return to Activity. And the PRA, or Progressive Return to Activity, outlines the state-of-the-art treatments as well as how to return members to full function. And we define what rest looks like, and then to get back to duty, and how that should occur through progressive activities. There's also a very comprehensive evaluation if you've had 3 concussion in the last 12 months. Next slide. We also have a policy for concussion in the non-deployed setting. And the tenet or the main principle is to evaluate as soon as possible for early detection of concussion. We know that early detection leads to the best outcomes. So as soon as possible following a potentially concussive event using standardized tools. It's also important that we document the mild traumatic brain injury in the health record. so that we can learn more about repeated brain exposures, repeated brain injuries. Next slide. This is a picture of the US TBI pathway of care. So having a system in place is very important. We call that system the Defense Intrepid Network for TBI and brain health. And we have centers very similar to, I think, your Forest Glade Center for rehabilitation that offers specialty services, standardized tools, and reports patient outcomes. We have 13 centers that are comprehensive, multidisciplinary in care, and we collect the same information. Those are patient-reported outcomes, objective tests, and administrative variables so that we can do better. We look at the data and try to improve patient outcomes. Next slide. This is my last slide. This is the way forward in our work related to concussion and traumatic brain injury. Because this conference was focused on mild traumatic brain injury, I did not go into details about moderate, severe, and penetrating. We also are looking at better ways to classify traumatic brain injury beyond mild, moderate, severe, and penetrating. I wanted to share with you my final slide on the way forward. So we created a policy, one big policy on warfighter brain health, and that should get released over the next 2 months. And this will be across the entire US Department of Defense, and it will continue to lay out many of the principles that I've discussed today. We also will be expanding the distance from 50 meters to 75 meters in the new policy for how to define a potentially concussive event. Much of that is based on our unmanned aerial vehicle, UAV or drone data from incoming fire, so that we know that there is munition load that is greater than in previous war with IEDs, improvised explosive devices. So therefore, we want to create a wider distance for soldiers to get checked out. We also want to leverage technology in a better way. We have 8 cleared devices, objective data that will help aid in the assessment of head injury. One of those devices I discussed earlier with blood biomarkers. We have 7 other devices and technology that can help improve our care. And then finally, we continue to perform lessons learned and process improvements through after action reports. That gets communicated to our joint staff and throughout the combatant commands worldwide so that we can improve and use data to further refine and get better at our care for mild TBI and concussion. And the last comment that I will mention is that it was brought up when we held a mild traumatic brain injury seminar in March and in Warsaw, that we needed to think about buddy aid and how to determine if someone has concussion on the battlefield, because you have to make quick decisions, and sometimes medical assets may not be there to make those decisions. So we are working on that to be able to help future fight for us and also to assist our partners in determining concussion at a buddy aid or not a non-medical personnel to be able to determine if someone is able to stay on the battlefield. Thank you for your time and your interest, and thank you for inviting me to your Congress.
Katie, thank you. Because we don't know that in order to be with us, you had to sacrifice your good night's sleep. So it's actually very important and valuable that you decided to connect to our conversation and share your experience. Thank you.
You are welcome.
Ще у Кеті хтось хоче щось спитати?
Що ж, друзі,
Okay, friends, we can actually state that the first introductory discussion with the key aspects is almost over, and we can actually check the time and say that it's 11:16. At 12, we have the second part. So we really want to start it like at 12 sharp, but now, like a preliminary question. We spoke of the Q&A session. Maybe someone has questions, maybe not in private networking space you'd love to speak of, but something like that should go in public. Okay, all the questions will go to the couloir space. Okay, we have 40-minute break now announced and coffee break, so enjoy. Yeah, on the first floor. Yeah, so of course listening to speakers is important, but coffees and teas and small talk is really important as well. Thank you so much, and it's much nicer. Yeah, especially now. At 12, we're waiting for you back.